Very delighted to have in person today's speaker. And with that, I will pass to Cesare, who will introduce our speaker.
Good morning, everybody. My name is Cezary Rydz, and I am a postdoctoral researcher at Dr. Dorota Skowrońska-Krawczyk here at Gavin Herbert Eye Institute at the University of California, Irvine. It is my great honor to welcome you to today's lecture and present today's speaker, Dr. Gustavo Aguirre. Dr. Aguirre is a professor of medical genetics and ophthalmology at the School of Veterinary Medicine at the University of Pennsylvania and works with dog models of inherited eye and retinal degeneration. His lab focuses on model identification, disease gene discovery, and defining molecular pathways linking the gene and mutation to the disease. Since 2000, his work has focused on developing gene-based and other therapies for translational applications. Dr. Aguirre earned his undergraduate veterinary and doctoral degrees at the University of Pennsylvania, where he also completed a residency in ophthalmology before serving as a postdoctoral fellow at the Wilmer Ophthalmological Institute of the Johns Hopkins University School of Medicine. He joined the faculty at Penn in 1973, where he rose to hold joint professorial appointments in the veterinary and medical schools. From 1992 to 2004, he was the Kasperi Professor of Ophthalmology at the James Baker Institute of Cornell University, before returning to Penn in 2004. His work has been supported by numerous grants, such as NIH, Foundation Fighting Blindness, and other organizations. Dr. Aguirre has received numerous prestigious awards, among which are Doctor of Philosophy degree from the University of Göteborg in Sweden, the Foundation Fighting Blindness Award, the Alcon Research Institute Award. Moreover, he was a recipient of the 2004 Paul Kaiser International Award in Retina Research, and in 2017, he received the prestigious Proctor Medal from the Association for Research, Vision, and Ophthalmology. He is a fellow of the Association for Research in Vision and Ophthalmology, the College of Physicians of Philadelphia, the American Association for Advancement of Science, and he has been a member of the National Academy since 2012. His groundbreaking research has led to the proof of concept studies of AAV-mediated RPE65 gene therapy in Leber congenital amaurosis. This eventually led to several clinical trials and commercialization of the therapy. Two of his other gene therapy studies in dog model are in phase 3 clinical trials, and two others are in other trials. We are very excited to host Dr. Aguirre as a speaker today in person, and the title of his today's talk is Retinal Gene Therapy from Models to Man: The Promise, the Problems, and the Lessons Learned. Without further ado, please welcome Dr. Gustavo Aguirre.
Thank you. It's great to be here. I was promised that it never rains in Southern California. Now the song is not always correct, but it's nice to be here nonetheless and meet friends, old friends, and make new ones. So I thought, since the progress made in retinal gene therapy has really been great in the past 24 years or so, 23 years, I thought it's time to take a look back and see what have we learned, what are some of the problems we have encountered, and then what lessons we learned to go forward. And I've listed here the support and disclosures. I wish disclosures were even longer, but it would be nice. Now, this was working earlier. Oh. We can disconnect this and I'll do it. Let me escape here. Okay. All right. So the work I'm going to tell you about today is work that we started in the late 90s with Art Sedesian, Sam Jacobson. At that time, Tomas Aleman was working in the lab at Shea Institute. And as most of you know, Sam Jacobson died over a year ago, just over a year ago, and was a tremendous blow, both as a friend and as a colleague. But life goes on. And this, we're moving along. Tomas has joined as a co-director of the Center for Inherited Retinal Diseases at Shea Institute. And the group there, though independent, totally independent from us, we've been such a pleasure to collaborate over so many years that it just seems natural to continue this collaboration. So in 2001, a paper we published in Nature Genetics really gave an eye to gene therapy. And it was really the first successful gene therapy that was done that restored vision and protected structure. And what was interesting is that most of you, probably all of you, don't know the backstory to this, because in October of '99, I submitted a grant to NIH to fund such a study. And it was not triaged, but it was totally trashed. And the items that were not considered important are the ones that I have here in bold. That the dog model, probably not worthwhile to do anything other than as a surgical exercise, could teach you nothing. And it was quite disheartening to get that. At the same time, we provided Foundation Fighting Blindness with the same grant because they had a program that they would accept grants that were relevant but not funded by NIH. I would consider them. Quickly turn around, and that was also rejected. So what was left for us to do is to keep moving forward without their funding, which we did, and publish this paper in Nature Genetics. Interestingly, though, Foundation Fighting Blindness and NIH became into a publicity fight. They were fighting with each other to claim credit for the study. They didn't fund it. And NIH would call me and say, FFB is really taking us to the cleaners with this publicity because they didn't do anything. And I said to myself, well, NIH didn't do much either since they rejected the grant. And but that was the beginning of that story. And the dog that was sort of the poster child for this was Lancelot. He went to Washington as organized by both NIH and Foundation Fighting Blindness. And that was a story that led us to begin thinking of potentially using other animal models for gene therapy. And in that period, the first one on the left is the LCA, which is a treatment of Lancelot with RPE65 mutation. After that, we moved on to achromatopsia, one of the channels in the outer segment of cones, an X-linked RP. And more recently, we've been moving on and working on Best disease and rhodopsin, and lastly, a form of LCA caused by a mutation in a gene called NPHP5. And I'll touch on these as we get along in the talk. What was really impressive with the treatment of, say, Lancelot and his group of dogs is that you restored function with one subretinal injection, tested about 2 to 3 weeks after the gene therapy. And the responses that were very low amplitude and only at the higher intensities were restored to normal waveform. And they were lower in amplitude because only about 25% of the retinal surface was treated. And it was stable. This is 12 months after treatment. So we have here the dark adapted ERG. The ERG photo response was restored, as well as the 29 Hertz cone ERG flicker responses. This really was a dramatic. No one expected, especially Sam and Art didn't expect this, because when they were doing the dark adaptation and the ERG, they decided, well, none of these ever worked before. So instead of really beginning at a very dim light to look at the threshold, we'll begin higher. And all of a sudden there's a response, so the dogs had to be re-dark adapted. And then the study had to be done using the very low levels of light illumination to look at the dark adapted threshold. The responses were stable for rod function, as you can see there in green. That's over a 3-year period. And then for the cone responses, again, for a 3-year period. And this was very dramatic. The ones in gray are the untreated eyes. And one of the dogs, you see here in the lower left, when the outer nuclear layer thickness is measured, then that area of treatment, which is delineated by the dashed lines, remained intact, while all in black is a surrounding dead retina. And then a 1.5 years later, when this dog and study was terminated, we looked at the histology of this. And you can see in this area here, the photoreceptor layer is perfectly normal. And if you can see the numbers, and as you approach the edges of the treatment area, the quality of recovery and normality is reduced markedly, which you expect. You're now approaching the no man's land of dead tissue. One of the problems is a treatment forever? And that's a question that Sam and Art raised early in their studies. After all, the studies in the dogs that we did involved 27 dogs that were all under 1 year of age, and we looked at functional recovery. Aguirre published a review in 2013 in which included about 123 eyes, of which 27 dogs were included in that. And most of these dogs were treated under 1 year of age. Those that were treated older, you had some good functional rescue, and some, there were a few failures. You always have in some of these treatments. And the critical thing is that the only assessment that they did was functional by ERG or vision. They did not look at structure. And one of the issues then that Sam and Art faced in 2013 is that on the patients that were treated, they saw a declining integrity of the photoreceptor layer in areas that were treated while there was a maintenance of visual sensitivity and function. And that, if you then, being not a pessimist, but a realist, if you keep seeing a declining outer nuclear layer with time, even though you have reasonable function, you find that eventually the two will cross over and you will have no function and no structure left. In a later paper that they published in 2015, they looked at the patients now for a longer time period. I think it was 4.5 and 6 years after treatment. And in 3 patients, you were maintaining visual sensitivity, visual function. When you plot the areas of sensitivity, they decreased. And this is in patients where the outer nuclear layer was also thinning. The group in the UK found similar findings and published in the same journal. They attributed this to the RPE65 expression not being robust enough in the retina or the RPE to maintain the human retina normally. So they are running a clinical trial in which they're using a vector that they have modified that supposedly gives you 10x the expression level of RPE65. It will be interesting to know. I think results are pending. So with Sam and Art, we decided to look at what happens when you treat dogs at patient-relevant ages. That is, when the retina has a structural abnormalities comparable to some of the patients. And 4 dogs were treated. We began here, we waited until they were about 5 to 6.5 years of age. And then they were treated with the clinical grade vector in one eye, the other eye not treated. And they were followed then up until they were 9, 10 years of age, period of about 4 to 5 years of age. Just to give you an idea of the cost, dogs cost $10 a day per diem, feed, water, and clean them. So the first part of the study cost $73,000. That's doing no experiments, that's just water, clean, food. And then the second part of the study, the per diem rates increased to $15 a day. And now we were dealing with a lot more money, $98,000. So the total study to do this was $172, give or take a few dollars, which means that, first of all, it's too expensive to do in the first place. In the second place, you don't know you're going to have the problem, so you're not going to do a study just in the off chance you're going to have a problem. And the cost is prohibitive because all the other things of OCT, ERG, behavior testing, all of that, that's in addition to the cost that I have just mentioned. So for that study, what we needed to do is be able to relate the retinal thickness that you see histologically with the OCT results. And that's something that Kristen Gardner and Art did in a wonderful way, looking at plotting the thickness of the outer nuclear layer in the upper, that you see histologically in the upper panel, and I'm having trouble getting there, and then doing the same thing for what you see on OCT. And you look at the curves, they're about the same, very similar. And the number was that per row of nuclei, it's about 4.48 microns. So it gives you an approximation of how thick the retina is histologically when you're looking at it by OCT. And then it required doing then injections, doing OCTs before, and measuring the area inside the dashed line and the dotted line, and then the area outside that before and at the end of study. And the bottom line for this is that the retina was normal, near normal, or about 60, better than 60% of normal. There was no degeneration with the treatment. However, in areas that were thinner than that, that were more degenerate, you see this scattering where the retina becomes thinner. And that's because you have progression. And that progression was comparable in the treated versus untreated areas. It's just, which tells you then the time of treating patients is not where they're degenerate, and also is not to treat globally because some areas of the retina are not going to be responsive to treatment. And that's where we stand now with the gene therapy work with RP65. I'm awaiting the results of the higher expression level that Mira GTX is doing. I don't think that will work, my own personal opinion. And the reason for that is that we had levels when we did the dose response curve of vector, we had recovery at low doses and high doses that were comparable. They were not better. And also you have areas that were degenerating that had very robust expression of RP65. So that I'd like to see what the results are, but it's some caution needs to be exercised. And it also is not having a patient come in and you just blow in the subretinal space vector in areas that may not be amenable to treatment. You really need to know where you're treating and why you're treating. So I'll show you a video here of two dogs. They were litter mates. One was treated and one was not treated at 6 weeks of age. The brown dog was not treated. This dog has a channelopathy. The cyclic cyclic GMP, gated channel, beta 3 subunit in cones is not functional. And you can see the dog has this moving gait. You can't see in bright light. The litter mate was treated and vision recovered. He's now a perfectly normal puppy that had success with gene therapy. This was really dramatic. And the other studies that were done in mice with both the beta 3 and the A3 subunits showed comparably successful treatment. And there's a group of sheep in Israel that have 2 different mutations of the alpha subunit. And those treatments are also successful, really dramatic. So the question is this, boy, it's a no-brainer. Take it to the clinic. In preparation to the clinic, just to show you some of the responses we have, the dogs that were untreated have absence of cone responses and recovery of cone responses after treatment. And this is a sustained. This goes up to almost 3 years, but we have this going up to 6 years. And that's both for the missense mutation and the genomic deletion in the beta 3 subunit. And that we published in 2010. That was quite exciting. The clinical trials, several groups have started the clinical trial. And I'll summarize it very quickly. It does not blow your socks off with responses. In fact, to me, it's been quite disappointing. The groups that have been using the human cone arresting promoter, that is at least in looking at expression of this gene in dog retina with this disease, it is a very low expressing promoter. A company called AGTC did a treatment with a human red cone opsin promoter, 1.7 kb size, and that gave you very robust expression in cones, in both LM and S cones. But there was no consistent, there's not something that you put in and you all of a sudden get a miraculous recovery. And that was surprising. The one that I like best to comment is that treated patients with achromatopsia did not open their eyes after surgery with a feeling of a miracle. The different shades of gray were not replaced by a range of colors. And that was just looking at both the objective assessment of vision. They did MRIs. They had areas where the field expanded. They had areas where the area of central acuity increased, but it was not something uniform. And this was comparable in both the alpha and beta 3 subunit mutations in patients. So it's time to think of why didn't it work? Because after all, you do this in mice, sheep, dogs, it works wonderfully. And it did not work in dogs, in people. It could be that the models are totally irrelevant to the human. That's always a possibility. And we don't know that. Certainly the mouse cones degenerate at a faster rate than in dogs and sheep. So maybe the human is more like the mouse. At the time of treatment, there are very few cones left. The promoters, though weaker, the HCAR, the human cone arrestin, those promoters are very effective in expressing genes and reporter constructs in the cones. So that's not an issue. I'll talk about photoreceptor deconstruction in a few minutes, but I'll give you the bottom line with this is that in dogs that are older, you do not, after 8 months or so, treatment is not successful, even though the transgene is expressed in the photoreceptor cells. It just doesn't work. That doesn't happen with a CNG A3 mutation in sheep. Sheep you can treat at any age, and they recover very nicely. So I'll go into deconstruction in a second. In all the animal models, the cone responses recover with treatment, yet there's not a single patient reported where you have cone ERG responses after therapy. There's something there, perhaps. The treatment is in the fovea, macular region. That's where the highest concentration of cones is. So I think the expectation is you treat, vision is recovered, and you can now drive a car and read after surgery. A bit of an exaggeration, but no, it is the area where cones are most diseased. So perhaps the most desirable area to treat is not the most optimal area to treat. And we should set our bar a little lower and go peripherally. And, also issue of amblyopia. And that was in some of the functional studies done in the visual cortex. Maybe amblyopia, you're treating too late and you're not improving at that point. Now, the story in dogs was really interesting. We found great success to treat less than 6 months of age, but not after. And the problem was that after 6 months of age, cones remain there in about the same number. They're only reduced by about 20%. And the transgene is expressed in the cones, even though they remain non-functional. So we had an idea, the work that Andres Komarmi and I did in now about 2012, was that perhaps what the cone outer segment needs is to then shorten and disappear and then reform when all the subunits are available. It's really simplistic, but we had nothing else to grab hold of at the point. So we used CNTF. Ron Wen, now in Florida, has had a very nice series of studies using intravitreal CNTF, where it shows that rods and cones shorten, the gene expression is markedly reduced, and that's transient, and then they reform again. So we thought that perhaps the way to do this is to do a subretinal injection in dogs after we first give intravitreal CNTF, wait a week, and then give the vector. And then test 5 weeks or so later. And just to make the table easier, everything green, highlighted in green, are dogs that had the CNTF first and then the gene therapy. And if you look at the positive signs, they all recovered function. The ones that are not in green are the ones that had PBS intravitreal, followed by CNTF, followed by the vector injection. And those did not recover function. But on the far right column is the number of weeks, of months after the gene therapy. And it shows that the transgene is present both in those retinas that recovered function and not those after that did not recover function. So the gene is there, it is being expressed, but it is not being assembled in a proper subunit to form a channel. And really, yes. And talk loud because my hearing is not great.
No worries. Was the cone function measured at 27 months? Or it was much earlier?
Yes, yeah, they were measured at the end as well.
Thank you.
One of the things that we realized that we didn't do as well as we should have done in that study is that what happens if we do the therapy and it doesn't work? What happens if we inject CNTF afterwards? And it works, it recovers the function. So the gene is there, it's being expressed, but until you allow the cone outer segment to reform, then it will not function. In young dogs and older dogs that have this disease, they have transient cone function, and then that function disappears. And that's because the alpha subunits can form a homotetramer of a channel, but it's only transiently functional. If we give CNTF to an affected dog when older, then they will again have recovery of cone function short term because the alpha subunits are forming a homotetramer channel, but that is lost within a matter of several weeks or a month. Paul Seaving was very interested in this and did a study on patients with CNGB3 mutations, not injecting CNTF, but using the encapsulated cell therapy devices of Neurotech implanted into the vitreous, which we also did in dogs. It works in dogs very nicely. Sadly, it did not work in the humans. The human patients did not show any transient recovery or permanent recovery of cone function when these implants were placed into the vitreous. So an approach that could have been useful in patients is implant. And if you implant, I mean, if it's allowed by all the boards in the regulatory agencies, et cetera, but the encapsulated cell therapy devices are available commercially by, I think Neurotech still makes them. So the questions still remain, why do animal models recover cone function? Human patients don't. I think that would be an interesting biomarker question that would be important to address. I think it has to do with the area you're injecting. Go for the less optimal, but maybe one that will work, and that's the peripheral retina. The area of treatment is where in the foveal and central region is where the cones are most affected. The studies being done by the companies that are doing this therapy, doing adaptive optics, looking at cone structure, but they have not published that. So we don't know what the structure of the cones are in these areas that are being treated. Looking forward to those studies.
Excuse me,
Yes,
I'm really sorry.
I'll get my,
Is not achromatopsia connected to the loss of fovea?
loss of fovea?
Yeah.
When we did these studies, we did not realize that dogs had a fovea-like region then. Okay, that's something that William Beltran found a few years later. So we don't know. And by the way we process the eyes, be no way of finding this out now. But it would be, and again, repeating the study, $15 a day, waiting until the dogs are older, it becomes a little difficult to, not to justify to a funding agent. I can justify it to myself, but I'm not able to print money. Again, the amblyopia issue is critical, but there's one about cone function that still bothers me. Why do patients do not recover cone function? And it may be that this is not a treatable disease in patients. That the models do not recapitulate what is essential for the patient population.
Excuse me.
Yes.
No, you during these experiments.
Sorry?
During these experiments, you told us that in dogs the cones function was recovered, but in human not. So they inject or implant the implant device in both of them. I mean, in dogs and
Subretinal
human.
injections
For both of them, it was
yeah.
implants.
Yes. I mean, in terms of the CNTF?
Yeah.
Oh, that it's implanted into the vitreous.
For dogs and human. Huh?
Yes, well, it was implanted into humans without gene therapy. And yes, it did not, no function was recovered. In dogs, yes. A study that we started about 2010 dealt with looking at X-linked RP. Probably the most common, if not the most, at the top 2 or 3 inherited retinal degenerations on the RP category in man. It's an extremely common disease worldwide. A number of patients affected on a worldwide basis. The gene most commonly affected in 80% of them is RPGR gene. And then you have the, in a few patients, there are other RP loci in the, on the X chromosome, but mainly is the RPGR. And most of them occur in what is called exon ORF15, an open reading frame that follows the end of the so-called normal exon 15. And William and Art and Sam in 2012 showed this successful treatment in dogs that you could either prevent the disease when treating before the degeneration developed, but whether the photoreceptors were abnormal, or you could arrest it after degeneration had started. So it was very clear that you needed to go towards a clinical trial. And the next steps were, is it a sustained expression? Is a disease correction stable? Both of those are yes in a dog. The effective dose range, we did, and we identified that. If you treated later the patient-relevant disease stages, can you have success? And that's a critical question because you're not going to treat a patient before the disease develops. So we decided, I'll show you part of the study, which we looked at 3 different stages: early, middle, and late. In late stage disease, you have about 40 to 60% loss of the outer nuclear layer. And you can see that the photoreceptor layer is reduced by about 50% here. The photoreceptors are abnormal. They were treated at 26 weeks of age. And then assayed, this is 40 weeks, right? Looking at the thickness of a photoreceptor layer. Area of treatment is a little dashed line. And then at probably 2 years later, after treatment, you have that area treated is preserved. Everything else around it is dead. And when you plot the outer nuclear layer thickness over time, the green arrow, the lower left shows the area of treatment. And after several weeks, it separates from the area that is untreated in the superior retina, and that remains stable. The lower one, the inferior retina, was not treated, so therefore it keeps degenerating. And in the superior retina, in the area not treated, it degenerates at about the same rate. Looking at the histology now, at 113 weeks of age, that's 2 years, almost just under 2 years after treatment, you can see on the right the area of treatment, on the left the area not treated. And you can see in panel D, you have untreated versus treated. Remember, the retina was not normal when we treated it, so we cannot make it normal. We can make it get back to how it was at the time of treatment, and that's how it is. That's how the retina looked at the time of treatment. When we look at gene expression for both rhodopsin, conarestin, it is recovered in the treated area. RPGR is expressed in the treated area and not the untreated area. And also you have I think that's the LMopsin, red-green conopsin, you have the expression of those in the treated area. Now, so it's really a very encouraging results. And then we did the ERG, again, treating at early, middle, and late stage disease, and now going to 157 weeks, a couple of years or so after treatment. And the responses are stable in the treated eyes. Obviously, when you're treating late stage disease, the retina is not normal. So you can get, the best you can get is a recovery and stabilization of the response, not a return to what was normal, because you've lost about 50% of the cells. So the aim of that study was to look at what happens when you treat. So in the 2012 paper and in 2015 paper, when you treat it at the early stage of disease, and the retina remained normal. And that we have followed now for 6 years. When you treat a mid-stage disease, like you lost about 40% of the outer nuclear layer, again, you remain normal. And then you treat a late-stage disease. And again, you treat and the retina remains normal. It functions normal. Vision that I have not shown, vision testing is also normal. That's been done for 6 years. And that's what we published with Art and Sam in 2015. Again, expanding the age of treatment and really encouraging results that led for several gene therapy trials being organized. The important thing to remember is a paper that Sam and Art wrote in 2018, looking at the average X-linked RP patient and progression of the disease. And progression for RODS will take about 4.5 years to determine that there's definite progression of the disease. And for Cohen's, it's 6.1 years. In other words, you treat now and you analyze 2 weeks later, you're not going to get an immediate positive response. If the treatment is terrible, then you'll know right away. But a positive response, you're not going to get immediately. And so studies done, the group that was at Oxford, that then became Biogen, then developed the treatment and resulted in very good results, except that there was a loss of, I guess, confidence by the company Biogen. And the report, the product was taken off the market and the study was terminated. And I have 5 minutes, right, Chris?
Yes, you have as much as you want.
Oh, 3 hours? No. One of the things that was critical, all the work we did was vectors using the IRBP promoter. Very effective in the dog. Turns out the IRBP promoter does not express in rods and cones in the non-human primate retina. So that study was repeated when we optimized doses and we found that IRBP was not good. And we then had to come up with these were using RPGR vector that was codon optimized and vectors that were stabilized, the RPGR. And using the GRK1 promoter, it was very effective. This product was licensed to AGTC by the University of Pennsylvania. And they decided to do a little variation of that and then have a different vector in which a AV2YF with GRK, so they're changing the capsid so it goes into the, eliminates proteasome degradation. And they had the codon stabilized. Well, we had done probably 50 dogs in the previous studies. They did 16 dogs in a very short study. And we're able to say they declared victory. It is effective. And with that, they gave up on the license to the University of Pennsylvania and the University of Florida and decided to go their own way. At that point, I was counting dollar bills in my sleep. And all of a sudden, they gave up on the license and dollar bills disappeared because the patent rights were broken by this lack of agreement with Penn. And the bottom line in terms of lessons learned is, I think our intellectual property office was terrible in that when we undertook this program to test this new vector, they should have said, remember, if you test it, they will go ahead and patent it separately and eliminate your patent. Instead, the answer we got is, oh, that's a cost of doing business. That's normal. So protect yourself when you have intellectual property. Get your own lawyer if you need to, if you can't trust the advice you're getting from your institution. But after all the effort has gone into these studies, it became a little problematic to lose that. So I'll end up with one slide, which happened yesterday, that Arsadesian sent me an email. So the vector that you see in the upper one, the one that Biogen gave up, was not effective, even though the claims were great at the beginning. A new company has started up that has bought, Beacon Therapeutics has bought the AGTC technology. And that is, I believe, owned by the same people who owned the intellectual property for the first vector. And they're now recruiting patients, both. They have done a study, which they reported yesterday, saying AGTC 501 was generally safe and well tolerated and showed robust improvement. I will wait until I see the paper for looking at robust. But now they're recruiting patients that were treated unsuccessfully with the first vector and now using it for treating the fellow eye. It's showing that that vector was really not an effective vector in preventing the disease. So I went longer than I should have, but I appreciate your attention. I really have enjoyed it. Thank you.
We have two questions from Zoom, and then we go to the room. So please use microphone. We have acoustic problem today, so let's just listen. Use microphone. So the first goes to Shri Ganesh.
Thanks for this excellent talk. I have a question regarding the optimal time for therapeutic intervention. You mentioned that you need about 2/3 of the photoreceptor population to be on board for successful intervention. And you use OCT measurements to, I suppose, get an estimate of what percentage of photoreceptors may be surviving. Let me ask you if you have done an even more cost prohibitive thing, which is AOSLO imaging of the treated versus untreated eyes. Thank you so much for the talk again.
Thank you. We would love to have adaptive optics equipment to be used in our facility, and we don't. That's something that it's in the works, and we would like to be able to get a grant for that because it's really essential.
It is extremely difficult to normalize ONL thickness based on OCT measurement because ONL thickness varies from region to region within a single globe. Which is why I think AOSLO would be a better tool to estimate rod to cone ratios in different regions compared to OCT. Thank you.
But the adapted Can I speak? Yeah, the OCT data was measured in exactly the same spot at all the time. So it's not that we were just taking random measurements. The same location that you saw in that drawing, the same squares are the ones that were analyzed repeatedly. So that the adaptive optics would tell you more about what's happening to the outer, the photoreceptor, which is critical. It's important to know the integrity of the photoreceptor, but those are purely measures of the outer nuclear layer thickness, not randomly, but at specific locations every time.
Tony. Dr. Saban.
Hi, great talk. Very much appreciate this seminar. My question was in the context in the beginning with RP65 gene therapy, where you saw quite different than in the X-linked RP, which was more of arresting the disease. In contrast, in the RP65 setting, you saw recovery. So you had a flat ERG, and then you administered the gene therapy, and then the ERGs came back. I was wondering how you explain that if one considers that perhaps those photoreceptors were dead, or perhaps they were injured and now you're revitalizing them. Maybe you can help me understand that if you don't mind.
No, the photoreceptors were not dead. They had, and surprisingly, you would think of this as a vitamin A deficiency in the photoreceptors, and they are abnormal structurally. The outer segments are abnormal, but they're not absent. So what you're doing now is providing the right chromophore to the opposite, and you're getting the recovery. And this is one of the nice things. Originally, when I started on this, I never was interested in early onset, rapidly progressing diseases. I wanted things that were slower, that resembled more the human diseases. And that was a really stupid thought. And the reason is with the early onset disease, especially the ones that lose function but preserve structure, you can get a readout of recovery right away. Well, you can't with the other ones. That takes years. So like in the CNGB3, the therapy restores function within, quickly, within a matter of weeks. The RP65, the same thing. One that I didn't talk about, NPHP5, where you have no cone outer segments develop. You do the therapy, cone outer segments now sprout. It really is a really gratifying thing to see, and function recovers. And that makes it, at least from a translational point of view, much better because it allows you to get a quick readout of efficacy.
Thank you very much.
Zach?
Thank you so much for that really amazing talk. So I was kind of curious, in an effort to like escape degeneration and maintain cellular homeostasis, do you think that human achromatoxic cones undergo this kind of irreversible epigenetic remodeling that limits the efficacy of the CNGB3 gene therapy?
I think it's a really good possibility. I mean, we looked at some limited degree of gene expression and never finished the study that should have been done, looking at global gene expression in this disease. But you have a downregulation of a huge number of genes. So it points out that you want to use a promoter that is not downregulated, because if you're downregulated, then the likelihood of having success is very low. But I'm almost certain that there's just a global downregulation of all the genes. The outer segments though do remain, at least we won't know that until the adaptive optics work is published in humans on these patients, in the patients, but the outer segments remain. They're abnormal, but they're there. So I don't know, you probably go to a low level of maintenance rather than functional activity.
Thank you.
Great talk, thank you so much. And my question is more general. So I wanted to learn your thoughts about this idea that there is this tipping point where, if you intervene early enough, you are able to stop the disease versus if it's too late, it will probably go into decline and degeneration. Do you think that this tipping point is universal for all the, let's say, genes that cause retinal degeneration? Or, it will depend on whether, for example, we are looking at RP65, so something located in the RPE versus something that affects directly the photoreceptor cells, whether this point, where the latest point for intervention will be the same or different?
RP65 is a problem. And the reason is it was really the most obvious disease to treat, that was the, quote, easiest, because you were targeting not rods and cones, you were targeting the RPE cell layer. And you were putting the one gene that was missing in terms of producing the part of the retinoid cycle. And it recovered. Now, what level? I mean, what the retinas are committed to the cell death pathway. It's interesting because you have several studies that have been done in models show that you have common pathways of cell death that the trigger is early on, and then you get to a point that regardless of what you do, you're committed to the cell death pathway. And I think the problem is that, well, we know a lot more about what happens in models. We know very little about people. And we also have, for years, the funding agencies have really turned their backs on studies of the natural history of the disease. Now they're back to natural history studies, partly because industry has pushed that, because they need to know a natural history before they can look at an outcome. But I think natural history studies and really precise using adaptive optics, OCT, not just a clinical exam and ERG, are critical to know what's happening to the photoreceptor layer, where it's happening. When we look at RP65, the degeneration is not uniform. There are areas that were not treated that are really, really well preserved, yet other areas, mainly inferiorly, that degenerate very fast. So you have topography issues in disease in animals, and it also happens in human patients. So we don't know enough, sadly, and it's very difficult to, you're not going to do the experiment in people, do multiple vectors, but what you could do is know more about the disease you're treating before you undertake the treatment. Injecting it and just saying it's going to be a success is not good enough.
Thank you so much. It was really a wonderful talk and extremely inspiring. And I think my question is a tiny bit connected to what Zach was asking, but I want to go back to the CNTF treatment. And I would argue that there's a very low probability of having a protein in cones or rods that is stable for 2 years, which you have seen no recovery of the vision in 2 years. So what would be your other hypothesis? Because my favorite one, but this is also my type of research I do, it would be epigenetic changes that happen. And how would you address that? If so, or whatever your idea is.
Well, the idea I've had is not that the protein is there, but it is being produced and degraded all the time. And it's not assembling into the outer segment, which is unusual. I mean, I would have expected if you provide the beta-3 protein at a time that the alpha A3 protein are being, and you would have the assembly as the going into the outer segment. And it makes no sense to me. Epigenetics would be a wonderful idea. I don't know how to look at it with the type of samples we have.
We can discuss about it.
Okay, good.
Thank you so much for your time and presentation. It was a really excellent presentation. So I have 2 questions regarding the RP65 gene therapy. The first question is, what was the rationale of using AAV2, not AAV1 at the time? Because depending on surgeon's hands, it can also target the photoreceptors and like ganglion cells. And second question is, what's your opinion on making 2 blebs, one above the macula and one below the macula? I'm asking this question because retinal surgeons in Bascom Palmer started making 2 blebs with a subretinal injection, not one large bleb.
We use the AAV2 vector at the time because that was available. It was not something that we chose that was available. It targeted RPE, but it also targets photoreceptors. And interestingly, we also use a CBA CMV promoter. We didn't use an RPE specific promoter. And that, when we looked at the expression of the transgene in the retina, we only found one cell in one eye where it was expressed in rods. Everyone was very specific to the RPE. And that's what prompted the clinical trial to move forward with what we had. We had like 40 eyes of dogs that we had treated, and we had used other vectors, but only in limited numbers. And we thought, if you keep changing and going back, you'll never get this to a clinical trial. So that's a point that we decided. The idea of doing 2 injections or 3, that's really very good because that allows you to place your vector in areas that will be amenable to treatment.
Hello, thank you for this presentation. I was just wondering about putting these blebs in and doing these subretinal injections. I imagine can cause some inflammation and some incite some damage in that way. Does the inflammation that it may or may not induce, probably induces, get in the way of the therapy itself? in terms of like the delivery of the gene and whatnot? Or is that interfering with the outcome at all? And is there something that is done about that to manage that?
So our approach is to forget about inflammation and prevent it because we want to see efficacy. So and that has been our approach all along, because once you, if you suppress, deal with inflammation, then you have two components. But if you do the treatment and direct it to getting functional structural rescue, and you suppress inflammation, the next step is to do it and allow the inflammation to take place and see what happens. And it had been very, very effective approach. Many retinal specialists were very worried at first about using using steroids topically, subconjunctivally, and even orally, just to control inflammation, but that's been done short term. One of the things, and this is off the record because I can't say who told me, but several of the clinicians who were involved in the achromatopsia study said that their approach had been to treat patients and not to treat uveitis, and all of a sudden they found uveitis was a problem. Yet all the reports is that you always get is that it's well tolerated. Whatever inflammation is there is minimal. And the same thing as with the RPGR treatment with AGTC. Again, I can't tell you who told me, partly because I forgot, but also I don't want to get into trouble, but also that has been a concern about uveitis. That has been an ongoing concern.
Yeah, thank you so much for your talk over here. So one of the themes that you mentioned a couple of times was the selection of an appropriate promoter. And I wonder is the reliability of promoter activity uniform across a single mutation? So from one person with a mutation to another person with the same mutation, is that promoter that you would choose going to be reliably active in those two people? And if not, maybe organoids would be a good screening model.
I can tell you work that is being done at Penn by Raghavi Sudarsan, and he's looking at 3 different models of retinal disease at late stages of disease and finding what genes are downregulated, with the goal of identifying those genes that are upregulated, that are in the photoreceptor, or that are expressed uniformly, so that that can be used for vector development. And this seems to be uniform. And there are 3 diseases. Your question dealt with one gene, multiple mutations. I'm now talking about 3 different mutations in 3 different genes. And that seems to be a uniform thing, but it really is. Organoids will be helpful. It will take a long time. However, you're treating patients not in urgent situations that require a treatment developed in 1 week. It needs a treatment developed that will be effective.
Thank you. Thank you for your nice presentation. It was so inspiring for me. Following the question of our friends, I don't know the name, it was about the inflammation after the injection. I think based on my experience, I'm injecting the implants in vitreous or subconjunctival. I think the inflammation and rise up intraocular pressure is something undeniable. But after some days, it will disappear. It is like that. It was like that in your experiments, or not?
I'll use this. I don't have
Yes.
I really can't say it will disappear. Some of it's smoldering, and it will last a long time. And inflammation is required. It requires treatment. And one of the things that many of the CROs that are doing testing vectors for different companies usually incorporate into the treatment, into their safety studies, a treatment arm where the monkeys or whatever, dogs or whatever species they're using are treated, and an untreated arm which is the one that will be more likely to be like in humans. But it's a real concern by many retinal specialists that too much treatment can be damaging to the patient.
Okay, so we had a wonderful conversation, great questions, and the final one go to our famous Vladimir.
Hey guys, how are you? Great presentation. I really enjoyed it. One comment and one question. My comment is we have learned from our mouse studies that there is a progression as we look from morphology, which can look terrible. And then when we do in vivo ERGs, they actually look quite decent. And then when we do behavior, it can sometimes be almost normal. So I don't think that saving the structure of the retina is necessarily the end game, because again, you can have great functional rescue, even if the morphology still looks terrible. That's my comment. And my question is, we and others have argued that for cones, supply of visual chromophore, possibly from the mural glia cells, might play a role in helping conopsin fold properly and then be targeted to the outer segment. So in your achromatopsia models here, and I think you kind of mentioned this, have you thought of maybe providing chromophore to see whether this can enhance the development of outer segments in cones and improve the rescue, both structural and functional of the cones?
That's really a neat idea. And you would provide the chromophore intravitreally? Yeah, that would be, yeah. That would really, it's, yeah. Maybe they're not utilizing the chromophore that's available or is not sufficient.
Or if they don't use it for a while, maybe the
Yeah.
production is downregulated. So that
No, we have found in the achromatopsia model is a downregulation. And the study that was never finished, sadly, because of, yeah, okay, yeah. But the comment that you were making about having good function, but more, it's not the structure that I was worried about, is the loss of cells.
Sure.
Then you have a problem. Then no cells, no function.
I guess this was wonderful. Again, let me thank you, and all of us wanted to thank you as well.